Obsessive-compulsive disorder, or as it is commonly known, OCD, is a specific type of anxiety disorder that is characterized by obsessions and compulsions. Obsessions are defined by recurrent and persistent thoughts, urges, or impulses that are experienced at some time during the disturbance as intrusive and unwanted, and in most individuals cause marked anxiety or distress. An individual suffering from OCD will then try to ignore or suppress such thoughts, urges, or images by neutralizing or replacing them with some other thought or action. This typically leads to compulsions. Compulsions are defined by repetitive behaviors or mental acts that the individual feels driven to perform in response to an obsession or according to rules that must be applied rigidly. These behaviors are aimed at preventing or reducing anxiety and distress caused by obsessions. However, the behaviors are not connected realistically with what they are designed to neutralize or prevent, and are usually excessive in nature. The Diagnostic Statistical Manual, Edition 5, or more commonly known as the DSM-5, gives specific diagnostic criteria to meet for a diagnosis of OCD. First and foremost, an individual must have the presence of obsessions, compulsions, or both. The obsessions and/or compulsions must also be time-consuming, often such that it produces distress or impairment in their social, occupational, or other important areas of daily functioning. It is also important that the obsessions and compulsions are not attributable to the physiological effects of a substance or another medical condition. Finally, the apparent anxiety is not explained by the symptoms of another medical condition or disorder. For example, an obsession with personal appearance, like in body dysmorphic disorder, or an obsession with pulling one's hair out, as seen in trichotillomania disorder. Like many psychological disorders, there is no apparent cause of OCD. However, it is believed that OCD is likely to be the result of a combination of neurobiological, genetic, behavioural, cognitive, and environmental factors that trigger the disorder in a specific individual at a particular point in time. Neurobiological causes of OCD have focused on a circuit in the brain which regulates primitive aspects of our behaviour. This circuit relays information from a part of the brain called the orbitofrontal cortex to other areas called the striatum, the thalamus, and the caudate nucleus of the basal ganglia. When this circuit is activated, these impulses are brought to an individual's attention and thus will cause them to perform a particular behaviour that appropriately addresses the impulse. Abnormalities or an imbalance in the neurotransmitter or brain chemical serotonin could also be to blame. Serotonin is the chemical in the brain that sends messages between brain cells, and it is thought to be involved in regulating everything from anxiety to memory to sleep. It has been found that people with OCD have an imbalance with this chemical, and environmental factors such as stress may be a trigger for OCD in people with a tendency towards developing the condition. Stress does not necessarily cause OCD, although a stressful event like being involved in or witnessing a road traffic accident may trigger its onset. Behavioural theory suggests that people suffering from OCD often associate certain objects or situations with fear. They often learn to avoid such things or learn to perform rituals in order to help reduce the fear. Once the connection between an object and the feeling of fear becomes established, people with OCD begin to actively avoid that object or situation and the fear it generates, rather than confronting and tolerating it. Cognitive theory, however, focuses on how people with OCD misinterpret their thoughts. Most people have unwelcome or intrusive thoughts at some point during their life, but for individuals suffering from OCD, the importance of those thoughts are exaggerated. Research has suggested that OCD runs in families and thus can be considered a familial disorder. The disease has been seen to span generations, with close relatives of people with OCD significantly more likely to develop OCD themselves. However, no single gene has been identified as the cause of OCD. A comprehensive evidence-based assessment is a critical step in accurately identifying the presence and severity of OCD. Obsessive-compulsive symptoms can sometimes be difficult to assess, given that they are often manifested internally, and individuals may not be inclined to recognise and report symptoms. There are a number of assessment tools, however, that can be used when diagnosing OCD. These assessment tools typically centre around diagnosing symptoms. They include diagnostic interviews, clinician-rated, and self-report measures. Free-form clinical interviews are the most common method for determining an OCD diagnosis in clinical practice. However, when an individual's presentation is complex and differential diagnoses are of a concern, there is a benefit to using standardised interviews in clinical practice as well. Most diagnostic interviews are derived from DSM-5 criteria, including the Anxiety Disorders Interview Schedule for DSM-5 and the Structured Clinical Interview for DSM-5. These interviews, however, typically increase patient and clinician burden, as they can require 1 to 3 hours to administer, depending on the diagnostic categories in question. The Yale-Brown Obsessive-Compulsive Scale is considered the gold standard assessment tool for the assessment of OCD. It comprises of a symptom checklist and severity scale to consecutively rate obsessions and compulsions. The checklist includes 54 common obsessive and compulsive behaviours, which are grouped according to thematic content, for example, contamination and aggression, or behavioural expression as seen in checking and washing. Symptoms that are endorsed over the past week are then globally rated by the clinician using a 5-point scale ranging from 0 to 4 across 5 different dimensions: time, interference, distress, resistance, and degree of control. Obsessive and compulsive symptom severities are then rated separately with scores from 0 to 25, with these scores then summed to create a total OCD severity score, which ranges from 0 to 50. This scale is useful in tracking OCD symptoms at intake and during and after treatment. A self-report measure that is commonly used for diagnosing OCD is the Florida Obsessive Compulsive Inventory. It is a quick 20-item symptom checklist that assesses 10 common obsessions and compulsions, which are derived from the Yale-Brown Obsessive-Compulsive Scale that has been previously mentioned. It also includes a 5-item severity scale that captures symptom severity and impairment over a month-long period. This includes time occupied, distress, control, avoidance, and interference. It is also important to note that given the distinction in symptom presentation and comorbidity patterns between youth and adults with OCD, several measures have been specifically designed or adapted for use in youth populations. There are currently a number of treatment options that are beneficial in the treatment of OCD. Cognitive behavioural therapy, or commonly known as CBT, is the gold standard in treatment options, and within that, exposure and response prevention therapy. Exposure and response prevention therapy involves 2 components. 1, provoking obsessions and having the patient experience their subsequent anxiety, while 2, refraining from engaging in rituals. The purpose of this process is to gradually extinguish the patient's obsession-related anxiety by having the patient learn by doing. When a patient repeatedly tests the predictions of the feared outcome by exposing themselves to their anxiety triggers and resisting the urge to perform rituals, the paired association between the obsessions and compulsions becomes weakened. By preventing rituals, the patient is able to learn that despite their anxiety and compulsive urge, the feared outcome will likely not occur, or at least not nearly as bad as imagined, and the anxiety itself will habituate on its own, as long as compulsions are not performed. Exposure and response prevention therapy typically lasts between 12 and 16 sessions, and is often administered on a weekly basis, although it can be delivered more frequently if need be. Another form of behaviour therapy that has been shown to be successful in treating OCD is systematic desensitisation. Systematic desensitisation involves gradually exposing a client to ever-increasing anxiety-provoking stimuli. This typically occurs in 3 steps. The first step is the identification of an anxiety-inducing stimulus hierarchy. The hierarchy is a catalogue of anxiety-provoking situations or stimuli arranged in order from least to most distressing. The second step is the learning of relaxation or coping techniques such as meditation. With a therapist's support and assistance, a patient proceeds through the anxiety hierarchy, responding to the presentation of each fearful image or act by producing the state of relaxation. The person undergoing treatment stays with each step until a relaxed state is reliably produced when faced with each item. This is the third step. As tolerance develops for each identified item in the series, the client moves on to the next. In facing more menacing situations progressively and developing a consistent pairing of relaxation with the feared object, relaxation becomes associated with the source of their anxiety. Thus, a gradual desensitisation occurs. Medications are also used in conjunction with CBT therapies to treat OCD. The main medications used are SSRIs and SNRIs. There are many treatment outcomes that can be assessed when looking at OCD. However, it is essential that these assessments are evidence-based to ensure that client deterioration is quickly identified and corrective action is taken in a timely manner. Using assessments that have already been mentioned, such as the Yale-Brown Obsessive Compulsive Scale and the Florida Obsessive Inventory at the beginning and end of treatment, can help clinicians determine treatment outcomes. Outcome questionnaires, such as the Outcome Questionnaire 45, can be used as a repeated measure throughout treatment. It assesses 3 domains that are of particular relevance to OCD: psychological disturbance, interpersonal problems, and social role functioning. Furthermore, the use of a self-monitoring diary where patients can note down any intrusive thoughts, urges, or feelings is a good way for patients to see if they are making any treatment gains.